Good evening and welcome this evening to our program. Don't let COVID-19 prevent you from getting screened for colorectal cancer. I'm your host, Dr. Neil Nandi. I'm a gastroenterologist here at Penn Medicine, and I'm joined tonight by a distinguished panel of faculty who have devoted and committed their careers to helping promote preventative care in our communities right here in Philadelphia and abroad. COVID-19 has changed our lives in no short fashion, but disease and illness still go on. Now, tonight, we're here to talk about colon cancer. This month, March 2021, is actually Colorectal Cancer Awareness Month. And we want everybody to have the right and access to get screened to prevent colorectal cancer. Now, did you know colon cancer is the third most common cancer in the country across all genders? And it is the second cause of death from cancer amongst all cancers. And yet, it is one of the number one most preventable colorectal cancers just by getting screened. And it is an amazing healthcare initiative with technology, with the right clinical history, and with the right doctor and knowledge that we'll impart tonight that you can empower yourself and prevent yourself or a loved one from getting colorectal cancer. So let's get to it. First up, I want to introduce one by one our faculty. We have Dr. Akin Oyalawo, who is a gastroenterologist here at the University of Pennsylvania. Also, Dr. Shivan Mehta, also a gastroenterologist. Dr. Richard Wender, who's the chair of family medicine. Dr. Carmen Guerra, also vice chair of diversity and inclusion here in the Department of Medicine. And our colorectal surgeon, Carrie Ahrens. These individuals have different and unique perspectives, and they're going to highlight certain topics that are very important to our conversation. So first off, I want to turn to Dr. Oyalawo and ask, Akin, when and how and why should we get screened for colonoscopy, especially during a pandemic? Can we get COVID-19 by going to the hospital and getting screened?
That's a great question, Neil. Thank you for moderating this event this evening, and thank you to all of you for participating, taking this time out of your busy lives to learn more about your health, or maybe you're doing this for a loved one, so you can spread the message to them. So we definitely appreciate your presence here and do everything we can to answer all of your questions this evening. As Dr. Nandi pointed out wonderfully in his introduction, colorectal cancer is very serious because it is the second leading cause of cancer death in the United States, and 50,000 people will die from this each year. About 1 in 5 of you, or 1 in 20 of you, or 5% of people will have colon cancer in their lifetime. And I'm sure many of you on this webinar know someone who's been affected, whether that's a family member, friend, colleague, whatever it is. And the reason why these deaths are tragic, I mean, they're tragic for many reasons, but to me personally, why they're tragic is that many of these deaths are largely preventable. And people often ask me, how can you prevent colon cancer? What are the risk factors for colon cancer? And there are different, nuances that we could talk about, but by large, the best way to prevent colon cancer is with colon cancer screening. And that's why we're here to talk to you this evening. Now, I just want to break it down a little bit so we're all on the same page in terms of terminology. You may hear us say colorectal cancer or colon cancer. We use those two terms interchangeably, and they both mean the same thing, which is that we're referring to cancer that starts within the colon specifically. You may know people who've had colon, and it can start in one organ and end up in another, can affect the whole body. We're talking about cancers that start within the colon that could spread to other parts of the body, like the liver or the lungs, for example. Now, the way that colon cancer screening works is that we want to find cancer before it actually becomes cancerous, before it becomes dangerous. And the way that we can do this is through colonoscopy, which is a procedure that we'll talk a little bit more about, but it involves using a tool that allows us to look inside the colon for precancerous lesions called polyps. And we can identify these polyps before they're even cancerous and remove them and decrease your risk significantly. Also, if someone happens to be unlucky enough to have a cancer and they get screening at an appropriate age, then we're much more likely to find cancer at a stage when it's curable, increasing your likelihood that you survive. Now, as great as this test is and as effective as this test is, we're still not doing a great enough job in the health system of getting people screened at the appropriate time. And unfortunately, about 1 out of 3 adults are still not up to date with their screening. And I'm not going to call anybody out, but maybe someone on this call falls within that category of the 1 out of 3. And maybe you're listening to me talk and you're thinking, well, I'm healthy. I don't have any issues. My GI system's been fine. Why should I get screened for colon cancer? And the reason why is that it often doesn't produce symptoms at an early stage. So all of those benefits that I mentioned, taking out these precancerous lesions before it can even become dangerous, You really see that when we're screening the asymptomatic people at the appropriate interval. By the time somebody starts to have symptoms like bleeding, like abdominal pain, like weight loss, anemia, oftentimes those cancers have spread to other parts of the body, and it's much harder to treat at that point. We really want to find you before you even have a cancer, before you even have a large polyp, and that increases the chance that you're going to have a life free of colon cancer. Now, the topic at hand is, obviously we're in a pandemic. You've been told by other health officials that it's good to stay inside, avoid things that aren't essential, socially distance, wear your mask, etc. And I'm here to tell you that here at Penn Medicine, and I'm sure at many of the other health systems within the city, it's completely safe to get a colonoscopy or any other screening test for colon cancer. In fact, we're seeing numbers right now that are pretty alarming, showing that the number of colonoscopies now compared to a year ago has gone down dramatically, as much as 90%. And we know now how to prevent spread of COVID-19 within the health system, prevent spread amongst patients, prevent spread amongst staff, and from patients to staff. And we're taking every precaution possible here at Penn Medicine to make sure that when people come in for their procedure, that they're going to leave the same way they came in. And that includes screening every patient who comes in for COVID-19, making sure that all staff who are involved with the procedure have access to vaccination, and wearing protective equipment the entire time while you're here for your procedure. And we know that the longer you delay your procedure, the higher your chance of developing colon cancer, the higher your chance of becoming a deadly illness. So I really want to emphasize to everyone who's on this webinar tonight that if you have questions specifically as it relates to COVID-19 and colonoscopy or any other screening test, that I'm here to answer that personally. And we want to do everything we can to encourage you to finally take that step to get your colonoscopy or other colon cancer screening test.
Hakeem, that was fantastic. I think that was a really great synopsis of why people should get screened early and not delay in the course of a pandemic. And you highlighted a couple of important things. If you diagnose or delay colon cancer later, then outcomes might be worse. But if we look early, then we can prevent a worse outcome. You even pointed out a misnomer in that too, and I want our viewers to listen, which is we call it colorectal cancer screening, but really what we're looking for is precancerous growths, polyps that we take out, little growths or nubbins of tissue, and we look for those. So some people are scared when they hear the word cancer in the term screening. We're looking for the polyps, we can remove them. And also, I like how you highlighted that all our employees, our staff, but at every level, at every part of the team are being vaccinated, wear PPE or protective equipment, and we clean the rooms before and after every single patient. And also, every patient gets screened for COVID within 3 days prior to any procedure. So, I feel comfortable and safe when I walk into our endoscopy unit every single day and take care of our patients. Now, you also kind of highlighted some symptoms early in your discussion, and I want to now shift to Dr. Wender and ask, there's a whole myriad of symptoms, right, that can present or sometimes not. Dr. Wender, can you kind of review a couple of things? What are the most common signs and symptoms of colorectal cancer? How can I know as an individual that I might be having symptoms? Will I know? And what's the right age? What's the right age? I hear all this talk about how the age has shifted. Perhaps you can shed some light on that, please.
No, thank you, Neil. I'd be delighted to tackle those issues. So I'll start with some good news. Since we've had a national effort to increase screening for colorectal cancer, the mortality rate from colorectal cancer has declined by 55% since the peak. It's really spectacular. But I have to back it up with some very concerning information. And that is, if you look at the mortality in people under the age of 55, it is now, after bottoming out, it is now going up and has actually gone up by 16%. So what explains this? And this is work led by a colleague of mine. I was just communicating with her earlier today, Dr. Rebecca Siegel, the American Cancer Society, and others, who started to observe a few decades ago that people who were born more recently are living their whole lives with a higher risk of colorectal cancer. This has a fancy name. It's called a birth cohort effect. It depends on the year you were born. So if you look at people born in the 80s and 90s compared to the people born in the 50s, the people born later, through every year of their lifetime, carry forward a higher risk for colorectal cancer. We do not know why. The obesity is probably explaining about a third of it, but there are other factors as well that we still are exploring. This has enormous implications for being aware of symptoms and for the age to screen. So let me talk about the symptoms first. Here's the first lesson, and it's really a critical one, and that is virtually anybody can develop colorectal cancer at almost any age. We've seen colorectal cancer down in very young people, even the teens very rarely, certainly in the 30s and the 40s. We are seeing cases, whereas years ago it was quite rare. It's still unusual, but it's happening. That means that there is no such thing as a set of symptoms that you can just ignore and dismiss. So if you have noticed a change in your normal bowel routine, we occasionally use the term bowel habits, the size and consistency of your stool, how often you go, whether you have abdominal pain or not, whether it's difficult to move your bowels or you have prolonged diarrhea. Listen, anybody can get that for a viral infection or a change of diet, or you're traveling for a week or two, then it returns to normal. But if it's persisting 3, 4 weeks, 5 weeks, you need to have an explanation. It doesn't mean you have colorectal cancer. You probably don't. But you need an explanation because some people do. The most important symptom of all to be alert to is rectal bleeding, bleeding on the toilet paper, bleeding in the toilet bowl. And I like to tell people, bleeding is not normal. There's no such thing as normal rectal bleeding. If you have bleeding, you need an explanation. And the best way to get that is start with your primary care doctor. I just was on a webinar earlier today of a young man, had rectal bleeding, went to his primary care physician who sent him on for a scope. He had stage 1 colorectal cancer because he bled very early in the disease. It's wonderful news. He was 35 years old. Really illustrates how this disease is moving younger. This also has a huge implication for the age to start screening. For years, we said the age to start was age 50, and a lot of people know that age, kind of remember that age. But due to this shifting younger, we are now recommending, starting with the American Cancer Society guideline in 2018, became the first major guideline to recommend starting at age 45 for everyone. There was a group who previously, a gastroenterology organization, recommending screening in the Black population starting at 45 because of a higher risk. Interestingly, this rising risk in younger people has largely been seen in the white population. And as a result, in terms of the risk of colorectal cancer, it's now equal between white and Black at these younger ages. So for everyone at average risk, meaning you do not have a family history, the age to start is 45. There's a new guideline that's about to be finalized by the United States Preventive Risk Task Force, also recommending age 45. So I don't think there's going to be any debate going further. Final point, guess what the screening rate is in people under age 55, 50 to 55? It's only 49, 50%. So even under the old guideline, only half of the population in the younger part of that age range had been screened. Now that we're going to expand to 45, we have an enormous amount of work to do. Siobhan's going to talk about the fact that we have options to screen. Doesn't mean everyone needs a colonoscopy as the first choice, but it does mean everyone needs to start screening at 45.
That was terrific. I think you highlighted a lot of important things. You know, there's certainly changes in your bowel habits. I bet our audience has never heard of that term, bowel habits, but they're habitual. But if you have a change in any quality in your bowel movements that doesn't go away, talk to your doctor. Ask them. It never hurts to ask. And that's actually when we can catch colorectal cancer early, okay, before it progresses too much. There's a lot of stigma attached around colonoscopy, but there's many different ways to break down that stigma and many ways to screen you. I do want to highlight again, if you do come of age, 45 being that new guideline that we're adopting now, even if you feel perfectly healthy, don't delay. Get screened. That's how we can actually push the envelope and get more people in to prevent colon cancer. Now, I spoke of stigma, right? Everyone has their own conceptions of what a colonoscopy is like, but you have to talk to somebody who either's been through a colonoscopy, okay, or who does them for a living. I want to speak to Dr. Siobhan Mehta, and I want to ask you, Dr. Mehta, what are the different types of colon cancer screening? Is it just colonoscopy? What's the best test? And if you could just kind of highlight, how do we go about doing it?
Sure. Thanks, Neil, for having us today. And it's really great to be here. And I appreciate everyone in the audience being here and to hear about this really important topic. And so we get this question a lot, and we've even seen it in the chat box already, which is, which tests should you get done to get screened for colorectal cancer? And I want to reiterate and make this point, which I want to make over and over again, which is the best test is the one that gets done. And to add to that, I'd say the best test is the one that gets done today or tomorrow. So don't delay. We'd much rather have you get a test done today than to wait and put it off. It's one of those things where, there's a lot of things going on in your life. It's sort of like I'm thinking about my taxes right now. Everyone puts it off. Nobody wants to do it. But because you have that deadline of April 15th to do it, everybody starts sort of coming together to do it. And we know from behavioral science and research that we do that people tend to procrastinate, and sometimes they need deadlines to do so. So Colorectal Cancer Awareness Month in March is the best time to think about, getting screened, following through, scheduling the test, talking to your primary care doc, and figuring out which test is right for you. So we've heard a lot about colonoscopy, but there are other options out there. And I would put those in the category of stool testing. So I'll tell you about some of the pros and cons of different testing options. So colonoscopy is more invasive. You certainly heard about it. But it's a test that is also more sensitive and can detect polyps that we can remove that can ultimately prevent you from getting later stages of colon cancer. And the other advantage about colonoscopy is that if you get it done, and if it's negative, you can actually wait an extra 10 years, meaning you don't have to worry about it for 10 years. And that's one of the reasons that a lot of my colleagues, whether it's primary care docs or gastroenterologists, often prefer that test because you sort of do it and you don't have to worry about it. There are other testing options that can be effective. Stool testing, things like fecal immunochemical testing. You've seen commercials out there, stool DNA testing. Both of those are available. They are recommended by guidelines, and we would be perfectly fine if you went forward and followed through with those tests. Particularly during COVID, when it may have been hard for people to come in or get rides for colonoscopy, we've actually been mailing out stool testing kits to patients to make sure that they get screened today and don't delay that process. We don't want you to wait an extra year. We don't want you to wait necessarily to get vaccinated. We want people to think about getting tested now because we know that if you don't do it today, you might just procrastinate it, and it's going to be the last thing on your list to do to follow through. Now, the one thing I'll make sure to emphasize is that this is for average risk screening. So that means that you don't have any symptoms, you don't have any family history, you don't have any other conditions. And so if you are at average risk, it's okay to do colonoscopy or stool testing. If you are at slightly higher risk, meaning you have a strong family history of colon cancer, you have had polyps before in the past, you have symptoms, things that Dr. Wender talked about, or you have a condition called inflammatory bowel disease. In those cases, you do need to get a colonoscopy. It is very important that you have to get a colonoscopy. The other thing I would emphasize is that if you get the stool testing done and it's positive, it's incredibly important that you follow through and get that colonoscopy. In about 5 to 10% of the cases who get stool testing, they will get a positive test. That doesn't mean you have cancer, but it does mean that you need to get a colonoscopy within a reasonable time frame.
And, that last point there, these non-invasive tests, these tests that don't involve a camera, going inside the intestine are really helpful for the right patients. They may require more frequent screening, but if they're positive, you don't want to make the mistake of being fearful of finding out the truth, because sometimes the positive test does not mean colon cancer. It may mean polyps, it means hemorrhoids, it may mean a million other things, that are not cancer. So this fear that we have in our society about cancer, it's real, and it's well-founded, but don't be afraid. The test empowers you. The test gets you a head start that other people may not have, right? So that's the point here. We had a poll earlier in the program, and that first poll, we have a second poll coming. The first poll was, are you uncomfortable or fearful of having a colonoscopy during the time of COVID? And at least last that I looked, about 80% of you said no, and about 20% were fearful. So we will hopefully are addressing some of the concerns that you may have, but everyone is getting vaccinated. We clean and take extreme measures to make sure our patients are safe. While we go on to our next one, our next session, we're going to introduce another poll, which is really going to ask, how many of you actually been screened for colon cancer? I'm curious if you have been screened. If you haven't, I'd like you to drop into the chat box why. What's prevented you from doing it? Is it the pandemic? Is it logistics? Is it insurance? What is the reason? We'd like to know. Now, I'm going to move our attention and shift a little bit. We know that colon cancer does not affect everyone equal. It is the third most common cancer across all genders and races and ethnicities, but we know that there are distinct differences between certain racial and ethnic groups. For instance, African Americans actually have a 20% higher risk of colon cancer than Caucasian populations, and there is a higher incidence and earlier incidence of colon cancer. And yet, they are also diagnosed at later stages of colon cancer. This doesn't make sense, and it's not right. I want to turn to Dr. Guerra and ask Dr. Guerra to go ahead and please elaborate. What are these differences? Why do they exist? And moreover, what are we doing about them?
Thank you, Neil, for the question, and thank you to everyone out there for sharing your valuable time with us to learn about colorectal cancer. And your question is a fantastic one about why these differences, racial differences happen. We know there are these disparities, as you well pointed out. Black Americans are 20% more likely to be diagnosed with colon cancer and 40% more likely to die of colorectal cancer. And as to why they are more likely, we still don't understand fully why that is. There is a lot of ongoing research that is looking into the differences in genetic factors, such as epigenetic factors in the colons of individuals of different races. And there is some thought that these epigenetic factors cause the colon to age at a much faster rate in some people more than others. But again, that's just preliminary research that still needs to be explored and validated. Others have talked about the diets. Differences in diets could contribute. And finally, differences in what we call the microbiome in different groups of people could also be contributing. The gut microbiome is a defense system against potentially errors that occur in our cells, genetic errors that predispose to cancer. So the bottom line is, great question. We still don't have a final answer on that. But we do know that a big contributor to the differences in actual staging, as you well pointed out, sometimes Black community members are diagnosed at a later stage. We know that a big contributor is the lack of access to screening at an earlier time when the stage could have been earlier, or in fact, this could have been a polyp and not even a cancer at all. And what explains different access to screening in some communities, in Black communities in particular, is what I call the social determinants of colorectal cancer screening, which essentially are a group of factors that determine whether you'll have access to colorectal cancer screening. So, for example, Black communities are less likely to have health insurance. About 11.5% of Black individuals do not have insurance in this country. And compare that to 7.5% of white individuals and 6.8% of Asian individuals. And when they do have insurance, some insurance plans actually have higher copays and deductibles that prevent those individuals from accessing colorectal cancer screening. Sometimes Black individuals, we have seen, have less access to hospitals and institutions that do colonoscopy. We've seen it here in this area, the closure of multiple hospitals, community hospitals that have served the Black communities. And so that's also a factor. And then there's factors that have to do with transportation. Black individuals have the highest rate of not owning a car. About 20% of Black households actually do not own a car. So when you think about a test such as colonoscopy, where you receive sedation during the test and so you need help getting home, you can't take public transportation, then that becomes a barrier. And finally, after colonoscopy, we do ask that another adult individual help you get home for the same reasons. You've had sedation and we want you to get home safely. And a lot of Black households don't have that extra individual who is at home and able to care for them. And so those are all factors that ultimately contribute to less likelihood of completing colonoscopy in Black communities. And so at Penn Medicine, upon recognizing all of these barriers that prevent some community members from accessing colonoscopy, in 2012, we responded by creating what we call a patient navigation program. And patient navigation is a wonderful program that allows us to help meet every individual's needs so that they can complete a colonoscopy, whether that's help with scheduling an appointment, help with understanding how to prep, how to make and take the prep, providing the prep free of cost, arranging for transportation and providing transportation to individuals that don't have other forms of getting home. And we'll even find you a medical escort if you need one because you happen to not have a family member or friend that can pick you up. So that's what navigation program is, and I call it concierge services for our patients so that they can complete a colonoscopy. And so those services stand ready to help anybody out there, you personally or a family member or a friend who you maybe have heard them say that they don't have a way to complete colonoscopy because they're missing one of those factors that we just talked about. And they're here to answer questions, simple questions sometimes. One of the questions that has been coming up in primary care, for example, that I know our navigators are also answering is, do I need to complete a COVID vaccine before getting a colonoscopy? And the answer is no, you do not need to complete your COVID vaccines. As you heard Neil and others say, we are taking every precaution possible, and colonoscopy is completely safe, even if you haven't had a COVID vaccine. So I urge you all to complete and help others that you love and your friends complete a colonoscopy, and we stand ready to help with patient navigation. And with those navigation services, we stand to also eliminate racial and ethnic disparities in colon cancer.
Absolutely. I'm so impassioned with just hearing what work has been done here within our own community at Penn to try to empower patients and make the process easier. I'm a doctor, and just trying to navigate healthcare for my own self or a family member is challenging. I wish we could do that for everything, but the fact that we have some type of a service like this for our patients where we can answer questions, help them with scheduling, help them with prep for colonoscopy is incredible. So thank you for establishing that program. Now, I want to address the elephant in the room, if you will. Through our chat, I've seen some people say that they have a fear of getting the test. And I can read between the lines. People are afraid of that cancer diagnosis, okay? And I understand that. I can empathize with that. So let's address it head on. And Dr. Carrie Ahrens, who is one of our colorectal surgeons, is going to help us address this. Now, Dr. Ahrens, we know that the best method or strategy here is prevention, right? Detect polyps if you have them, or if you don't, keep screening. That's the best test, right? But what does it look like for a patient if they have an early stage of cancer, okay, stage 1, for instance, okay, where I believe there's like a 90% survival rate, and a stage 4, where there's a delayed or very widely spread cancer, like a 15% 5-year survival rate. Can you juxtapose the two? Can you contrast the two and tell us what do we do if there's a colon cancer, and how curable is it really?
Yeah, thank you, Neil. And hi, everyone. Good evening. And I just wanted to say it's really a pleasure to be able to participate in this important event tonight. I want to thank you all for coming and learning more about colorectal cancer, because certainly having more helpful information is always the first step to being able to help yourself or being able to help someone that's important to you. And Dr. Nandi brought up a really important point. It's a spectrum. Right? It's much better to find things or prevent things before they happen, but certainly if you find something, it's better to treat it when it's early as opposed to when it's very late. So I'll sort of talk a little bit about those two different things as I go through briefly tonight. So as has been said, my name is Carrie Ahrens. I'm one of the colorectal surgeons here at Penn. I've been on staff here for about 10 years, and it's really been my privilege to help take care of our cancer patients at our cancer center. Now, you may be asking yourselves, what exactly does a colorectal surgeon do? I ask myself that too. But with respect to colon cancer and rectal cancer, I am primarily the person who's responsible for removing the part of the colon or the rectum where the cancer is found. And I'm lucky to be a part of a really great team of colorectal surgeons here at Penn who staff all of the major hospitals across the Penn campuses. So tonight I've been asked to talk a little bit more about the treatment options for colorectal cancers, as well as address some of the possible misperceptions about treatment. So as you've already picked up in some of the comments earlier tonight, colon cancer, like all cancers, are best managed if they're found early. We want to prevent them, but they're certainly better managed if they're found early. That's why screening and appropriate testing is so important. So I really encourage you to get screened or tested if you're having symptoms. Now, on my end, once identified, once you find a colon cancer or rectal cancer, surgery really is the best way to cure colorectal cancer. Not chemotherapy, not radiation, as some of you may have heard. Sometimes patients may need additional treatments like chemotherapy or radiation before or after surgery, but surgery is really the best way to cure the disease. So I wanted to spend a little bit more time talking about that process, because that really is sort of a very daunting process for loved ones or for friends or for family, or if you yourself get that diagnosis. So the first piece of advice that I give patients when they're diagnosed with cancer or they know someone is make sure you bring someone with you to your appointment. Or at least, if that's not feasible in this time, have someone available to listen on the phone. You're going to be getting, those patients are going to be getting a lot of information about treatment in a very short period of time. It comes at a time when you're already very anxious, so it's always nice to have another set of ears to sort of digest the information that you're getting. So once diagnosed with colorectal cancer, doctors will do what we call staging. So we basically, using scans, are looking elsewhere in the body, anywhere else in the body that we know cancer cells can spread, to see if there's any spread of that particular cancer. Now, this gets to your question about treating early versus late. So late cancers are ones that have spread to different parts of the body, and those are always more challenging to treat. So if you find spread, we often talk to patients about chemotherapy first, oftentimes instead of surgery, which is also very effective. But certainly, again, the best way to cure the problem is to find it early and find it at a point where it hasn't spread to different parts of the body. In fact, most people can still work and carry out their normal routines while they're on chemotherapy. Again, we want to prevent you from getting to that point, but that's one of the more common misperceptions that we hear is chemotherapy going to be something that is debilitating for everyone? So there are still options if you have a later stage cancer. That option is usually chemotherapy. If there's no spread of cancer cells, which happens in most cases, again, if it's found early, then your doctor will talk to you about surgery, which, as I mentioned, is really means that we're taking out part of the colon or the rectum and putting things back together or reconnecting things. Now, there are a variety of ways that we can accomplish this, and they're all very effective. We can do this laparoscopically, which is a method where we use small incisions for a camera and an instrument and do the surgery that way. Or we can even do it robotically in some cases, which is another very innovative way of doing surgery with smaller incisions. But even if you're not a candidate for one of those options, we can still do the operation in the very traditional manner with a bigger incision in the middle. And the recovery after surgery is, especially with the smaller incisions, is actually quite quick. If things heal properly, I tell patients that they may be in the hospital maybe 4 to 5 days. But you probably won't feel 100% or back to your baseline for about 4 weeks. So it is a process of recovery, but most people are bounce back very quickly after surgery. In some cases, your surgeon may talk to you about adding chemotherapy after surgery, depending on what that final stage of cancer is. So before I end, I wanted to discuss some of the other misperceptions that I hear about surgery and cancer that I think are really important to sort of talk about. The first is that, a lot of patients think that they're going to be bedridden after surgery or severely limited in their activities or not be able to have a normal diet, a normal healthy diet after surgery. And that's really just not true. Most people are up and walking around the day after surgery in the hospital and eating normal food before they get discharged from the hospital. The second thing that I hear commonly is that surgery causes the spread of cancer. Again, this is entirely not true. As I mentioned earlier, it's really the only way that we can cure colon cancer if we find it, especially if we find it early. Lastly, probably the question I get the most often is, or the concern that I get most often is, if I have colon cancer, I am concerned that and I have to have surgery, I'm concerned that I'm going to have an ostomy or a bag. And that's really definitely not true. It may be necessary in some cases, but certainly the vast majority of people that have colon surgery or rectal surgery do not need an ostomy or a bag. So I know you've been listening to a lot of talks, and I think we're all anxious to get to your questions, so I'll end there. Thank you again for joining the discussion and asking your questions. I look forward to answering.
Thank you so much, Dr. Ahrens. That was really great. I think you kind of head-on addressed, what surgery is, what our techniques are, very minimally invasive in many cases, that chemotherapy is sometimes required. And one myth about chemo is that it's intolerable. That's not necessarily very true. Chemo's come a long way. It's gotten a bad rep. And it's not that there's no side effects at all for some patients, but it can be very well tolerated. The bottom line that you should hear is that colon cancer, if you have it, is very treatable. It's very curable. And if you're lucky, you're going to have a wonderful and kind, compassionate surgeon like Dr. Ahrens. So I want to turn to our audience, to our panel here, and I want to thank our audience listening. We're not done yet, so stay tuned more. I have been trying to take notes, looking at the questions that have been coming in, and I'm going to try to get through as many as possible. I'll answer a few along the way, and I'm going to point and shoot to our faculty to go ahead and answer the questions for you. And while I'm doing that, if this was helpful, please let us know. Drop that into the comment box. We want to do more of these. We want to know that it helps answer questions. If you have suggestions for other ideas, let us know. If you find that something was not answered, let us know. We will try to get back to you. So a couple of things about process. Okay, that's the category. One is, and I'm going to have Dr. Oyalawo try to answer some of these questions. And by all means, our faculty anybody can chime in. But some of the questions were about prep, right? I have a fear of doing the prep. What's the prep like? What would you tell our patients?
Yeah, I noticed those questions as well, and there's no way to get around it. Many people who've had the colonoscopy before say that the prep is the worst part, and you can look at that as a positive or a negative. Before talking about the prep itself, I'll mention there's a reason why we put people through this torture, and the reason is that when we're trying to identify these polyps and what that is, I also want to ask what is a polyp. It's really just a benign piece of tissue in the colon, and we know that they grow very slowly over time, but after years, or in cases where it's more aggressive in months, that could develop into a tumor. So to be able to identify these lesions, sometimes they're smaller than the size of a pea. We really need the colon to be empty of debris so that we can see them very clearly. And the more we remove, the less likely it is that there's going to be a missed polyp, and that's going to decrease your risk of cancer. Now, the prep itself usually involves drinking a laxative the day before the procedure. It also involves not fasting. I want to say that that's a myth. Some people think that you can't have anything at all by mouth the day before, and I would say do not do that because you can come in dehydrated. It just means that you can't have any solid food. So if you can't see through the food, you can't have it. But anything that's clear, juice, jello, water ice, popsicles, all of that's acceptable. And every different doctor may have some modifications based on your health history and medications that you're taking, but by and large, that's typically the process. And the evening before going into overnight, you'll complete the laxative. You will run to the bathroom, so make sure it's a time when you're available to do that. But like many people have commented, I think that if you can get past that initial hurdle, then afterwards everything is smooth sailing. And as Dr. Mehta pointed out during his conversation, if that's something that you're not ready for, there are other options as well too.
100%. And for the prep, people complain about the taste, but there's actually tasteless preps, entirely tasteless preps, and that's pretty much the standard that we use in most of our endoscopy suites here at Penn Medicine. You can mix it with anything that tastes good to you, or it can be tasteless instead of some of the salty, nausea-inducing taste of some of the other preps. And if you've had a poor prep or poor experience with a prep before, talk to your doctor. There's always a strategy, okay? There's always some trick up our sleeves that we can pull out and customize to you. I have one more question for you, Dr. Ayala. Can you take an Uber or other type of transport, public transport home after a sedated colonoscopy?
Yes, another common question that we get. The mode of transportation home is not the concern. Whatever way you want to get in and out of the procedure is up to you. But what we want to make sure is that when you come for a procedure where you receive sedation, that as Dr. Guerra pointed out during her portion, it's important that someone is there with you so that if for some reason you're not feeling well after the procedure, someone can be with you to make sure that if you need attention or if you need to call us to have some questions answered, there's someone specifically looking out for you. So the actual form of transportation can be what is the most convenient way for you to get home, but we do require that someone that you trust come pick you up from the procedure for that reason.
Very good. And yeah, absolutely. We take great pride in your safety. So we want you to take a reliable, trustworthy person to have that you entrust to take you home. So we prefer a family member or friend. Question for Dr. Wender. I won't read the entire question, but one of our audience members asked or relayed a strong family history of cancers in multiple organs. Now, for the person who asked this question, I have not had the opportunity to analyze it or draw a family pedigree in detail, but it was multiple different types of cancer in multiple family members. Dr. Wender, when you hear of that type of a history in a family, what does it make you think, and what kind of advice would you give that family?
Yeah, it's such an important question, and we do hear it often. And the most important message for people who have a strong family history is that they may be part of a family that carries a genetically inherited risk. And there are certain cancer syndromes. Probably the one that people have heard about the most is BRCA, which increases risk for a number of cancers, particularly breast and ovarian cancer. Fewer people have heard of a very common syndrome called Lynch syndrome, which is also carried through families and inherited through families. And it can go to men, to women, to boys, to girls, that increase your risk of colorectal cancer and other cancers. So when I'm in the office and somebody tells me about, my sister had a colon cancer at a young age, the first thing I do is say, let's talk about other family members, who I get a very careful family history. Dr. Guerra and I both do primary care, and we're kind of in the middle of a genetic revolution right now where she and I are recognizing that it's the responsibility of the primary care clinician to get enough family history to see if genetic testing is indicated. And if we're not sure, we can refer that patient to a genetic counselor who can, and more now we're doing that actually over the phone. It doesn't necessarily require an in-person visit to see if testing is needed. The best thing to do, if we do think a genetic test, is to do that test in a living relative who was affected by the cancer. If they're negative, we don't worry so much about the relatives. If we don't find one of these syndromes, it doesn't mean that your risk is not elevated. We would treat you as an elevated risk patient who should begin screening with colonoscopy only, as Dr. Mehta said, not with a stool test, and begin at a younger than usual age. And that we vary depending a little bit on what the age profile was in your family.
So I think what you highlighted there was that there are genetic syndromes out there. So if you're looking at your family pedigree at the next, family physically distanced gathering for the holidays, and you're listening to each other speak, don't ignore it. Go talk to your physician and ask for help. This is a well-developed science. We know a lot more than we ever did before, and we can tease out whether you're at elevated risk or not. And regardless, we will give you the right treatment and the right preventative screening. I want to ask you another question, Dr. Wender. One of our audience members asked, I have diverticulosis. Does diverticulosis increase my risk of colon cancer?
Yeah, and there are others who may know the science better than I do, but to my knowledge, we do not consider diverticulosis. For those who may not know, they're these little holes that you have in the lining of your bowel. They're very common. As many as 50% of the population have them. but not associated with a higher risk of colon cancer. There's a couple other complications that they occasionally cause, either bleeding or they can become infected, so don't ignore symptoms. But colon cancer is off the list. It's not a higher risk.
Absolutely concur. So about, some studies say 50 to 80% of Americans over age 80 years old have diverticulosis, but 80% of America does not have colon cancer. So they're common and typically benign. If you've had diverticulitis, which is an infection where that little outpouching gets infected or inflamed, sometimes, rarely, very rarely, that can be a colon cancer masquerading, as diverticulitis. And so in that instance, you get antibiotics, you get better, no surgery. And then we recommend a colonoscopy, usually 6 to 8 weeks later at the earliest, to make sure that you don't have anything like that. So very good question. Next, I want to talk about a couple of other fears about the procedure itself. And Dr. Mehta, I'm hoping you can answer some of these questions. One of the most common fears about a colonoscopy is someone has heard of or knows someone possibly that's had a perforation. What is a perforation and how common is it really?
Yeah, so every time we do the procedure, we want to talk to the patient about the risks and benefits of the procedure. And so that's an important conversation that we have. And any procedure that we do or any medication that you take will have some side effects. And so the biggest thing that we're concerned about with the colonoscopy is something called a perforation or putting a hole in your colon. And that's because, we are putting an instrument in the colon and we are placing air in the colon. Now, data, when we look at population studies, the risk of that is quite low. And that risk has actually been going down over time. A lot of it is because we have more trained endoscopists. We have endoscopists that do this 500 to 1,000 times, which means that they have a lot more experience with it, and they understand how to do the procedure well. And so when we cite what the risks are, it's about 1 in 3,000. The risks are slightly higher as you get older or if you have other complications or things like that. But we do think it's a very acceptable risk. We think that the benefits of colon cancer screening and screening colonoscopy outweigh the risks. And so that is really important to note. And even if a patient does get a perforation, it is actually very treatable. It's usually sometimes with surgery, often without surgery. Patients can get treated for a few days in the hospital, and people can live very, very reasonably with a good quality of life soon afterwards.
Yeah, and what Dr. Mehta said is very important there, that sometimes if there is a perforation, the body is such an amazing miracle that if there is a perforation, it's usually tiny, and oftentimes the body will heal itself. You may need antibiotics. It may be painful, but it doesn't always necessarily require surgical intervention. Dr. Mehta, I want to ask you another question that our audience asked, which was, how do I know that all my staff have been vaccinated? Is a vaccine necessary for them, for me to get screened, to feel safe? And do I need to get my first or second dose of whatever vaccine I get in order to come get a colonoscopy?
Mm. And the short answer is no. The first thing I would say is that while this isn't a talk about colorectal cancer screening, we do want everybody to receive the COVID vaccine. So that is incredibly important for the pandemic and something that we would recommend to all of our patients as soon as it is available to them. Now, we as Dr. Oyolowo mentioned, there's lots of strategies that we have in place to make sure that there has been minimal to no transmission of COVID in our facilities. We do screening of all employees when they come in to make sure they don't have any signs or symptoms of COVID. The vast majority of our staff have already been vaccinated, and we all wear PPE at a higher level, meaning we typically wear a mask. Most of our staff in the endoscopy suite are actually wearing N95 masks, and we also wear eye protection, and that's something that's mandated for everybody across all of the staff. And so the rates that we've seen among patients coming in are incredibly low, and the rates of spread have been incredibly low. So it's actually safer to come in and get your colonoscopy than it is to go to your local grocery store.
Yeah, and then that's the important thing, right? We take utmost precautions. All of us can laugh that we've learned to recognize each other just by our eyes, because that's all that's peeping out behind our PPE. Thank you, Dr. Mehta. Dr. Guerra, I wanted to ask you some questions that came along as well, and they particularly regarded insurance. Okay, if there's challenges with, does it matter if I have Medicare or Medicaid? Does that affect if I'm eligible to get a colonoscopy? And does insurance cover colonoscopy screening at age 45?
Those are great questions, and the answer is almost universally yes. Almost every plan covers colonoscopy and colon cancer screening. The age question is a good one because I believe, as Dr. Wender said earlier, that we are going to see a change. So currently, insurance companies are required to pay for screening starting at the age of 50. As you heard Dr. Wender say, the guidelines are about to change, the U.S. Preventive Services Task Force guidelines. And it's those guidelines that determine whether a service is covered or not. And those guidelines are due any day now. And when they are published, you will probably see that the new age to start colonoscopy is age 45. And it'll be at that point that the policy work has to begin so that the policies are put into place that will allow insurance companies such as Medicare to begin to pay for screening starting at that age. So it should be very soon that all insurance companies will cover screening at age 45, but we're not quite there yet. We'll need the guidelines first and then the policies in place after that. Thank you for the great question.
Absolutely. And as Dr. Guerra just said, policy is important. Policy empowers us to advocate for our patients, right? Evidence comes, policy, and then you get to reap the benefit of screening. Okay, you deserve it. I know we're close on time. I want to ask Dr. Ahrens a very important question about diet and colon cancer. And then before we conclude, I'm going to tell you how you can get screened here at Penn Medicine or where else you can get screened as well. Now, Dr. Ahrens, we know that, diet is incredibly, profoundly important for human health. Dr. Guerra earlier mentioned the human microbiome, right? We're just learning so much about it. Can you tell us a little bit about what you would recommend or what we know about diet and its role in colon cancer?
Yeah, that's a great question. And something we certainly get asked a lot is did I do something to cause this cancer that I got or something like that? I think by and large, there are a number of established risk factors for colon cancer. Probably the most important one that you should probably pay attention to is age, right? So that's why we've been stressing about 45 or 50. We really want to start screening early because we know that the older you get, even though it's not very common compared to some other cancers, the older you get, the higher chance or higher risk of getting colon cancer. So screening is certainly very important. Some of the other risk factors that you may hear about certainly will be diet, obesity, exercise, those kinds of things that are within our control. We don't necessarily know exactly what it is about diet that will trigger colon cancers to happen, but certainly there is an established relationship between some kinds of high-fat, low-fiber diets and people that get colon cancer.
Absolutely. And, it's important that, a healthy diet really is associated with healthy outcomes, but diets that may be higher in fat or processed foods in general, right? Now, when it comes to colon cancer specifically, we cannot generalize everything. There have been some studies that associate, not prove cause and effect, but associate red meat, particularly when red meat has been charred or charcoalized. It kind of transforms the red meat. That's considered a carcinogen by the World Health Organization and has been associated in some models with colon cancer, but we're still learning more. So the best advice we can give you is eat your vegetables, okay? Now, before we conclude, a common question is, look, I've listened to this 1 hour. I've learned more about colonoscopy screening, how we're trying to keep patients safe against COVID. And we've talked about what the barriers are and what we've done to give you access, right? So that's the keyword, access. If you would like to get screened for colonoscopy, don't hesitate any longer. Talk to your primary care doctor. Our access center has a number, and I'll go ahead and spell it out very slowly. That access number, while you get your pen ready, is 215-349-8222. You can call, and our staff will help assist you in getting screened or scheduled for a colonoscopy. So I want to respect everyone's time here tonight, okay? Faculty, thank you so much for joining us and giving us some insights in how we can empower our patients, get rid of myths and misconception, and get successful colon cancer screening in the hands of our patients. And to all our attendees this evening, we put this together because we truly care about you. We want the best for you, and we certainly don't want a pandemic to delay the healthcare that you deserve. Colon cancer is common. Colon cancer is preventable. Colon cancer is treatable. Thank you all for joining us, and I wish you a good night.